Hello, this is Sean Yazdani. I'm a structural heart disease specialist and interventional cardiologist at Carey and Heart and Vascular, and I would like to go over a tricuspid valve replacement, a case we recently performed utilizing transcatheter techniques. The main pathology seen in tricuspid valve disease is tricuspid regurgitation, and this is usually in conjunction with other type of heart disease such as left-sided heart disease. In these conditions, usually therapy is directed toward the left-sided disease. When tricuspid regurgitation itself gets treated, it is usually treated with diuretics. Um, and mainly this is to take care of the right-sided manifestations of tricuspid regurgitation, such as lower extremity edema. Surgery for isolated tricuspid valve regurgitation is rarely performed. However, in the past few years, there is a lot of discussion regarding treating tricuspid regurgitation on its own and whether this actually helps patients' prognosis. To that end, many transcatheter techniques are being developed to address this issue, and many clinical trials are ongoing in this field. The patient I'm presenting today is a 71-year-old female with a history of sick-sinus syndrome, atrial fibrillation, whose status post permanent pacemaker implant. Patient has had a few-year history of severe tricuspid regurgitation with resultant right-sided ventricular dilatation and lower extremity edema to a point where she was being very symptomatic and it affected her daily life. Her left ventricular systolic function is preserved, and eventually a patient underwent tricuspid valve repair utilizing a 28 millimeter Medtronic annuloplasty ring at the same time that she also got Mays procedure and surgical occlusion of her left atrial appendage about a year ago. Unfortunately, she presented again after a few months with lower extremity edema and right-sided failure, and her echocardiography showed her to continue to have severe tricuspid regurgitation. This is a clip of her tricuspid regurgitation, which showed the dilated tricuspid annulus and resultant severe tricuspid regurgitation. Our pre-procedural planning was to access the right common femoral vein with a 14 French Edwards sheath and place a 26 millimeter S3 Edwards valve into the annuloplasty ring utilizing TE for imaging. We did approach the tricuspid valve from the right femoral vein using a 26 millimeter S3 valve, which was mounted reverse on the balloon. And we proceeded with lining it up with the annuloplasty ring before deploying it. This clip shows inflation of the balloon and the deployment of the valve. Unfortunately, as noted in this clip, the valve moved atrially as it was deployed. And you can see from this clip that even though the valve is deployed, there is still a central regurgitant jet through the valve, in addition to a rather large perivalvular regurgitant jet next to the valve, between the valve and the septum. Before we proceeded with placing a second valve, as noted, after the second valve was placed, the central regurgitant jet fairly disappeared. However, we still had significant amount of perivalvular leak. By echocardiography, we measured the gap between the valve and the septum to be around 1.4 centimeter. This is the 3D manifestation of the valves being in place with the perivalvular area right next to the septum. With the help of an Agilis catheter, the perivalvular area next to the valves was cannulated, and an Amplatz wire was placed through the perivalvular area into the right ventricle. Agilis catheter was then advanced over the wire into the right ventricle. Vascular plug was deployed as noted in this clip. 3D presentation of the valve after the deployment of the plug showed appropriate occlusion of the perivalvular leak with normal functioning valve. This is an echo clip of the tricuspid valve after vascular plug. As noted here, the tricuspid regurgitation has completely resolved within the tricuspid valve and is minimal through the plug. Patient was discharged 2 days later, and before discharge had another echocardiography. This is a clip from the pre-discharge echocardiography, which shows total resolution of the regurgitation, both within the valve and in the perivalvular area. She was seen at the clinic a week after discharge and again after a month. And upon follow-up, she had complete resolution of her lower extremity edema with significant improvement of her symptoms of fatigue. And she was able to do her daily activities now without much limitations. Thank you.